Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Hope everybody is doing well. We were coming off a stretch of night shift up in the medical intensive care unit. Luckily, we did not see any acetaminophen toxicity, which is what we're going to be talking about today. Although we did have a beta blocker toxicity, which is a video for a future or a topic for a future episode. So as one can see, we're going to be talking about acetaminophen toxicity or Tylenol toxicity today. This is a really important topic, a really critical topic, one that unfortunately is not uncommon. All right, we're going to be talking about what acetaminophen or Tylenol is, usual dosing. We'll talk about how common toxicity is, including the highest risk populations. We'll talk about the metabolism, both normal metabolism of acetaminophen and then the toxic metabolites that can cause toxicity. We'll talk about how to diagnose it. We'll talk about the Rumack-Matthew Nomogram, antidotes including N-Acetylcysteine, supportive care, liver failure, transplant, prognosis, high-risk populations, all that good stuff. So this is going to be chock full of rich, hopefully nuggets and tidbits. We'll also sprinkle in some of our anecdotal experience. And at the end, we had a couple practice questions. So thanks for sticking around, and hopefully this is a high-value episode for you all. As a friendly reminder, none of this is intended to be acted upon as medical advice. Please check out the episode description or hang around till the end for the full disclaimer. No further ado, acetaminophen toxicity. Starting with what acetaminophen is. So as we've kind of implied already, the brand name in the States at least is Tylenol, but this is the brand name, so we'll be talking about the generic, which is acetaminophen. And acetaminophen, for those of you unaware, which probably is not many of you, is primarily an analgesic, so for pain, or an antipyretic for fever. So analgesic is pain, antipyretic is fever. And you can get it OTC, over the counter. You also can certainly get a prescription. There's certain combination prescription products combined with things like opiates, which might be brand name Norco, which is hydrocodone or acetaminophen. Our night shift brain is flailing. There's also things like Percocets. You can combine in cold and flu medications too, where it gets mixed with things like antitussive medications and other stuff. So there's lots of combination pills, and this is one of the reasons that toxicity can be so common, because folks don't often realize that there's acetaminophen in these combination pills, and then they're taking acetaminophen, they're taking the combination pills, and sometimes they actually get some degree of toxicity from that. So always check what is in the combination pills you're prescribing and certainly taking too. The usual dosing in an adult for acetaminophen is 325 milligrams to 1,000 milligrams per dose. Oftentimes the pills come in 325 milligram pills, but not every time. We've seen 500 milligram pills. I don't think we've seen 650, but maybe there's 650 milligram pills, but primarily we've seen 325 and 500 milligram pills. Now you can take up to 1,000 milligrams in a single dose, but the caveat to this is the maximal daily dose that we like folks to stay under is less than 4 grams of Tylenol per day. All right, some institutions actually say less than 3 grams, and there's certain populations where you should stick to less than 2 grams per day. So if you think about the dosing, anywhere from 325 milligrams to 1,000 milligrams per dose, if you're taking these higher doses, the 1,000, that's, just a couple doses a day would get you to that 2 or 3 or 4 gram per day max. Now, 4 grams per day or 3 grams per day is safe for the, quote unquote average person, but if you're on certain medications or have certain conditions, sometimes the recommendation is to stick to less than 2 grams per day. And that would be folks like chronic alcoholics, because they have some degree of underlying liver injury already. So if folks are daily drinkers or heavy drinkers, you have some kind of derangement in your ability to metabolize acetaminophen safely. So the recommendation is to take less than 2 grams total per day. People on different medications that are CYP inducers, CYP-CYP. This is an enzyme that can be involved in the metabolism of many drugs, but certain drugs can induce this. Antiepileptics like phenytoin or carbamazepine or phenobarbital or rifampin, which can sometimes be used to treat different infections. There's a whole list of them, but any of these, the recommendation is to have less than 2 grams of Tylenol per day, just because you have increased production, which we'll talk more about, of NAPQI, which is one of the toxic metabolites. So anyone on CYP inducers, take less. Anyone on medications that are hepatotoxic or toxic to the liver, things like isoniazid, valproic acid, methotrexate, all these can cause some degree of underlying liver stress. So adding acetaminophen on top of that can lead to additional liver stress, and that's why the recommendation is less than 2 grams per day in those folks too. Anyone with chronic liver disease or folks on Coumadin actually, because the acetaminophen can potentiate the INR effect from Coumadin. So all of these folks, chronic alcoholics, patients on CYP-inducing medications, patients on direct hepatotoxic medications, patients with chronic liver disease, or on Coumadin, all should take less than 2 grams per day. Otherwise, the recommendation is either 3 or 4 grams per day total. So keep in mind combination pills, keep in mind the dose of acetaminophen you're taking, and keep in mind what chronic conditions might be out there or other medications that patients are on that might affect the safe maximal dose. In pediatrics, it's a little bit different. We're going to be focusing mostly on adults, but in pediatrics, it's 10 to 15 milligrams per kilogram every 4 to 6 hours, maximum of 75 milligrams per kilogram per day would be the recommendation. So why does this matter? Why are we starting by talking about dosing and maximal day doses per day and all that? Well, the reason is because overdose of acetaminophen, toxicity from acetaminophen, is actually the leading cause of acute liver failure in the USA and other higher income countries. And that's huge, right? Acute liver failure you can die from. Many people do die from it. Those that survive often can have chronic liver disease or sometimes even need a liver transplant. So this is an incredibly morbid condition, and it's one that unfortunately is not uncommon. So epidemiology and risk factors for acetaminophen toxicity. Well, a couple stats just to further frame the conversation here. And one of those stats is that acetaminophen toxicity accounts for 40 to 50% of acute liver failure cases in the USA. All right, intentional self-harm as well as unintentional repeated exposure to higher levels of acetaminophen all contribute to acute liver failure. So this is almost half of the acute liver failure cases in the USA are from acetaminophen toxicity, either intentional self-harm or unintentional repeated supratherapeutic dosing. Risk factors for toxicity at lower doses are the things we talked about, right? The things that should keep a patient to take less than 2 grams per day total: chronic alcohol use, malnutrition, chronic illness, enzyme-inducing drugs, right? We talked about rifampin and carbamazepine and phenytoin, underlying liver disease, right? All these things are why the max in that patient population is less than 2 grams per day rather than the less than 3 or 4 grams per day. And then the combination products, just to drive this point home, combination products of acetaminophen and something else, again, often opiates, are common culprits for toxicity because folks don't realize that there's acetaminophen in those combination products. So how does acetaminophen cause toxicity? What is the pathophysiology, the mechanism at play? Well, to understand that, we have to start by understanding the normal metabolism of acetaminophen. Okay, so the normal metabolism, and we'll go through kind of the pathway again, but we're just going to read it out to start, involves glucuronidation and sulfation. This is a way to metabolize a drug, to take the drug and break it down into its non-active forms. And glucuronidation and sulfation are around 95% of all metabolism for acetaminophen. So this is the vast majority of the acetaminophen is metabolized using glucuronidation or sulfation. And when it's metabolized this way, it creates a non-toxic metabolite. And this non-toxic metabolite you just excrete out, you just get rid of it, no issue at all. The challenge with toxicity is that a smaller amount of acetaminophen is not metabolized through this glucuronidation and sulfation. It's metabolized by something called the CYP2E1. This is an enzyme that the body has that metabolizes drugs. And about 5 to 10% of acetaminophen, even in the normal metabolic pathway, goes through the CYP2E1 enzyme. And that actually produces something called NAPQI, N-A-P-Q-I. Okay, and this is a toxic intermediate. So this is acetaminophen, you ingest it, 90 to 95% of it gets glucuronidated or sulfated, and it's just excreted in a non-toxic form. But even in someone healthy with normal acetaminophen metabolism, 5 to 10% goes through the CYP2E1 pathway, and it gets broken down into NAPQI, which is a toxic intermediate. But in most people, this NAPQI is detoxified by something called glutathione. All right, this is, getting a little confusing, so let's keep track of it. Normal metabolism, glucuronidation, and sulfation. Non-toxic metabolite excreted out. Normal metabolism is a small percent, 5 to 10%, gets CYP2E1. Acetaminophen is metabolized through the CYP2E1 pathway into NAPQI, a toxic metabolite, but in folks who with a normal metabolism who did not take too much of the drug, that toxic metabolite, NAPQI, is detoxified by glutathione, and that's just then detoxified into a non-toxic additional metabolite that's excreted out. Where we run into problems is in overdoses or in folks who took too much. Because this pathway, this glutathione pathway that detoxifies the toxic metabolite NAPQI, gets saturated, gets overworked. There's only so much of it in the body. And that leads to accumulation of NAPQI. And when then that NAPQI accumulates, it causes hepatic necrosis or liver injury. It also causes some mitochondrial injury. But all this then leads to liver injury. AST and ALT, our liver enzymes, get elevated. Our blood starts to get coagulopathic, we get encephalopathic, and we can go into multi-organ failure. And this can lead to acute liver failure, which can lead to death even. So what happens in toxicity is the CYP2E that breaks down the acetaminophen into NAPQI, the NAPQI, which then should be detoxified with glutathione, there's just too much of NAPQI, right? Because we took too much acetaminophen. So we don't have enough glutathione to detoxify it all, and that NAPQI builds up and leads to liver injury. Okay? So this usually takes, if we deplete more than 70% of our glutathione stores, that's when we start to see liver necrosis, liver injury from the NAPQI that's building up. If we look at this in a larger pathway form, and if you're listening to this in podcast version, apologies, we'll try to describe the figure we have here. But what it essentially is you take acetaminophen, right? You take Tylenol. And the two non-toxic pathways that the Tylenol is metabolized through is glucuronidation and sulfation. And that creates these non-toxic metabolites that are just excreted. Right, and this is about 90 to 95% of your acetaminophen goes into these non-toxic metabolic pathways. But you get CYP2E1, about 5 to 10% of the Tylenol you take is metabolized through the CYP2E1 pathway into NAPQI, which is toxic. But in a normal person, there's not a ton of that NAPQI, and our glutathione detoxifies it into a non-toxic second metabolite, cysteine, mercapturic acid, all that stuff, and then it's just excreted. But when we overwhelm this glutathione pathway, when we deplete more than 70% of it, we start to get a buildup of NAPQI, and that NAPQI, when it builds up, can cause direct liver injury. And if that liver injury gets too bad, it leads to liver necrosis. When the liver stops working, we get transaminitis, coagulopathy, altered mental status, encephalopathy. It can even lead to lactic acidosis, renal injury, and even death. All right? So this will then play into our treatment, because essentially what we do when we treat it is we give N-Acetylcysteine or NAC, which increases the amount of glutathione we have, which allows us to detoxify more of that NAPQI. But we'll talk more about that. All right, this figure is a nice Wikimedia figure, but it's a good figure. But we put the link there because it's theirs, not ours. So clinical course, what do you actually see clinically? We kind of understand the pathophys now. We understand what's happening when we take too much acetaminophen and you get buildup of that NAPQI and we don't have enough glutathione to detoxify it. Sorry, had to wet our whistle. And then we talked about the normal metabolic pathways, but what are we actually seeing clinically? What are we seeing bedside? You know, how does this progress? What are patients experiencing? Well, there's 4 stages of acetaminophen toxicity, and this is really important, and you will see this. Stage 1 is 0 to 24 hours, so pretty much day 1. And this is mostly GI symptoms, nausea, vomiting. You know, you might get sweaty, you might get a little pale. And at this point, the interesting part is your labs might be normal. You might not yet have the transaminitis or coagulopathy. So patients come in mostly with GI symptoms. And that's tough, right? A lot of things can cause GI symptoms. But it's important to ask if you've been taking medications. Yes, I have. What medications have you been taking? Acetaminophen. How much have you been taking? You know, XYZ. So it's important to screen for toxicity of acetaminophen in folks with GI symptoms, because obviously it's very nonspecific. But that's stage 1, 0 to 24 hours. Stage 2 is then 24 to 72 hours, or 1 to 3 days. And this is when folks start to get sick. You start to get more focal abdominal pain in that right upper quadrant. Why the right upper quadrant? Because that's where your liver is, in the right upper quadrant. All right, your liver starts to swell. It starts to stretch your liver capsule and cause pain. You then start to get your transaminitis, which is rising liver function tests, an increase in your ALT, your AST, your bilirubin goes up. This stage 2 is when you might start to get coagulopathic. Your INR might start to prolong. And the GI symptoms sometimes actually improve. They sometimes actually get better, other than the pain, but the nausea, vomiting, and all that. But this is where patients start to manifest with lab work that shows that they're getting really sick. And if this goes untreated, it can progress to stage 3. And this is the stage where people can die. This is 72 to 96 hours, or, day 3 to 4. And this is when we get peak hepatotoxicity. All right, folks might get jaundice. They might turn yellow in color. They get severely coagulopathic, so that INR and PT and PTT skyrocket. Your liver is involved in glucose regulation, so you start to get hypoglycemia, or your glucose drops because your liver can't regulate your glucose levels. You get a high lactic acidosis. You get acute kidney injury, AKI. You get encephalopathic and confused, and your liver function tests, your AST and ALT, skyrocket, usually multiple thousands, right? Sometimes as high as double-digit thousands. And if this is not intervened on, and even if it is, if it's not intervened early enough, this can lead to death. This is the stage where people can die from profound liver failure, leading to multi-organ failure and death, right? So this is day 3, 4, all right? Stage 4 is 4 days up to 2 weeks, and this is recovery. If you make it through stage 3, you tend to get recovery. You tend to get complete liver regeneration. Sometimes you have a little residual liver injury, but the liver's hardy. If you can get it to stage 4 without complete liver failure, sometimes you can get hepatic regeneration. In survivors, labs often normalize over several weeks. But again, if you don't start to recover, so if stage 3 does not go to stage 4, you do need liver transplant or you can die. So just to say it out loud, stage 1, I like to think of it, it's day 1. Stage 1 is day 1, 0 to 24 hours, nonspecific GI symptoms. Labs might be normal. Stage 2 is days 1 through 3. And this is where labs start to become deranged. Stage 3 is 3 to 4 days, and this is where you can die. This is where you go into liver failure. If you make it to stage 4, though, this is where you start to get recovery. If you don't make it to stage 4 and your stage 3 just keeps worsening, you might need a liver transplant. So these are well-described stages. They will be clinically apparent. This is what it happens, and this is really important to kind of keep in mind. That patient who took too much acetaminophen who comes in 4 hours afterwards in stage 1, they might look relatively okay, have some nausea, vomiting, their labs not be terrible, so it can give you this false sense of reassurance, but you really have to have a high index of suspicion. You have to intervene early and aggressively to try to prevent stage 3 from getting worse to the point where their liver fails. So what is the initial ED and ICU approach, the initial management algorithm? Well, like anything with sick patients, primary survey. Make sure they're protecting their airway. Treat for hypoglycemia. Treat for shock. So this is a kind of aggressive supportive care like we do for all of our critically ill patients, trying to address the things that are going to kill the patient first. When we're talking to these patients, though, if they're able to talk, or family members, history can be really key. And the questions that are really key is the time of ingestion. This can be incredibly important, which we'll talk about in a second, to look at this Rumack-Matthew Nomogram. So time of ingestion is important. Sometimes this is really simple. Sometimes it's, I took a whole bottle of Tylenol at this time. Sometimes it's more complex, right? Someone's like, well, I've been taking this much Tylenol every day for the last 3 weeks, but then this day I took a little bit more, and I don't really know the time of ingestion. But if you can pin down a time, critically important. The amount makes sense, right? How much Tylenol you took is super important as well. This can sometimes just be a complete indicator that the patient is going to get really sick. They need N-Acetyl-Cysteine. They're at risk for liver failure. You maybe even should transfer them to a liver center if you aren't one for some of these massive ingestions. So the amount can be important. Product, either immediate release versus extended release. This is critical too, and I think sometimes we forget to kind of ask or look into this because extended release, the timeline is going to obviously be much different than intermediate release. Co-ingestions are important too. One, to see if you should be expecting toxicity from any other ingestions, and two, sometimes co-ingestions change the timeline in which the drug is metabolized. It sometimes even changes your gastric emptying, right? If you take something, co-ingest something that slows your gastric emptying, that might mean you're going to reabsorb things later on. So co-ingestion is important. Obviously, intent, was it intentional to commit suicide? Was it unintentional? And then risk factors. Do folks have risk factors to get worsening liver injury, right? Maybe they're a drinker, maybe they already have liver disease, those types of things. But the big things that you're always asking about, and this is really for most tox cases, are time, amount, intermediate versus extended release, and co-ingestions. All right? Maybe we'll think of it like TARC, time, amount, release, co-ingestions. Kind of like that. Just made that up right now. TARC. Cool. Okay, immediate actions after the primary survey and some history keeping. If the timeline says they're less than 4 hours from ingestion, this is kind of this magical number we're going to talk about that isn't really magical, but is important. If they're less than 4 hours from ingestion, they say, I drank this whole bottle of acetaminophen and I came right into the emergency department, it was just an hour ago. Consider activated charcoal, right? This is 1 gram per kilogram, although this is not medical advice, so always look up your dosing, max of 50 grams. This is if they have a protected airway, because this can cause vomiting and things. So they have to be awake and protecting their airway. You shouldn't try to be shoving this down someone's throat who's minimally responsive. An extended release product, sometimes it'll help up to 8 hours from ingestion, but if it's less than 4 hours, you really should consider activated charcoal, okay? That can help slow absorption and improve, decrease the maximal serum levels that are gonna happen. Okay, so immediate actions less than 4 hours, consider activated charcoal. Get your labs, right? Get a Tylenol level, get your liver function test, get coags, get a metabolic panel, glucose, lactate, blood gas. Ammonia is not unreasonable. If they're female, get a pregnancy test, look for co-ingestions with an ethanol level, salicylate level. Sometimes a urinary tox screen, but this is a little question mark E. Lots of negatives here. Probably could be a topic for a whole separate video. And then when in doubt, when the timeline is in doubt, so they're like, I don't know when I took it, or maybe they won't tell you when they took it, or maybe they don't know, or maybe they're not very responsive. Or if it was 8 hours from ingestion, just start N-acetylcysteine immediately. And we'll talk more about N-acetylcysteine and NAC coming up here, but this is the antidote. And the reason that you don't start it on everybody necessarily is because some folks won't get to a high enough serum level where they need N-acetylcysteine. But N-acetylcysteine is life-saving in patients who have acetaminophen toxicity. This can save their life, and it's a relatively safe drug. So when in doubt, give it, okay? Don't hold back, just give it. All right, what is this nomogram people talk about, the Rumack-Matthew nomogram? This is classic discussion every time people talk about acetaminophen toxicity. And it's a nomogram that maps out the Tylenol level compared to the time from ingestion to help give an idea on if they need treatment or not. So again, this is not our figure. We appreciate the use of it. And this is essentially a figure that looks at hours from ingestion. So you need a timeline here. And that's why when in doubt, if you can't get a timeline, you just give N-acetylcysteine. So this is on the x-axis, hours from ingestion. On the y-axis, Tylenol plasma concentration. So you obviously need a Tylenol level for this. And then it looks at the Tylenol level from time from concentration. And if you're above the line, you should be treating with N-acetylcysteine. If you're below the line, you don't necessarily have to treat with N-acetylcysteine, okay? So treatment should be administered if levels above this solid line. So at 4 hours, that's when it starts. 4 hours post-ingestion, this is your first kind of marker here, right? So if you're above 150, I know it's a little small, if you're above 150, if your Tylenol level is above 150 at 4 hours, give NAC. And then there's an 8-hour, 12-hour, 16-hour, all that. So if someone's like, I ingested my Tylenol 7 hours ago. And then you look on the Rumack-Matthew Nomogram, you go to the 7-hour mark. This says, I can't quite see, but it says something like 80. If your Tylenol level is above 80 at 7 hours, give NAC. If it's below 80, you can monitor it. Now, there are some exceptions to this that we'll talk about, and you obviously need a good timeline for this. Oh, no, my drawing pad might die. But if you're above this level, this is really important to treat with NAC. Okay, let's continue moving on, and we'll talk about this in more detail. So this nomogram is not useful, okay, not useful if the Tylenol ingestion is more than 150 milligrams per kilogram per day. So if we just say someone's 100 kilograms, just to give an idea, 150 times 100, hopefully I don't do math wrong, but I think that's 15,000 milligrams in a day, okay? Just for a 100 kilogram person. Obviously someone smaller than that, 50 kilograms, if I did my math right the first time, that's 7,500 milligrams per day. And we said doses are 350 to 1,000 milligrams. So this is not a ton of pills. It's a lot, but it's not a ton, especially if someone is smaller. So if someone took more than 150 milligrams per kilogram per day, then you just treat with NAC, okay? If someone has been taking more than 4 grams per day for more than a couple of days, you just treat with NAC. Or if anyone has elevated liver function tests, you just treat with NAC. So the nomogram is not useful for any of these patient populations. Obviously, we also talked about if you don't know the timeline, if there's a doubt on the timeline, if it was more than 8 hours ago, just treat with NAC. When in doubt, treat with NAC. Poison control, big shout out to poison control here. You can Google it. You can Google poison control's number, call them. They are a great resource. You should be calling the poison control, at least in the United States, can't speak for other countries, but you should be calling poison control for all of these patients. All right, antidote therapy, let's dive more into it. We've been talking about NAC or N-acetylcysteine for a little bit now, but why does NAC work? All right, it replenishes the glutathione. And if you remember, we said that acetaminophen, we'll abbreviate it APAP, most of it gets metabolized, 95%, through glucuronidation or sulfation, but then 5% gets metabolized through the CYP pathway into NAPQI. NAPQI, we said, is toxic, but our glutathione usually sweeps in and detoxifies it. But if we overdose on it, we don't have enough glutathione, so NAPQI builds up and causes hepatotoxicity. But what N-acetylcysteine does is it replenishes the glutathione. So if you give N-acetylcysteine, this glutathione gets replenished, so then you are able to detoxify more NAPQI and decrease the amount of hepatotoxicity. All right, it also enhances conjugation, it detoxifies NAPQI. Timing is best if it's less than 8 hours from ingestion, but it's still indicated later. All right, so again, get this started early, be aggressive with it. It can save people's lives. Dosing, again, not medical advice, so definitely confirm all these, but IV N-acetylcysteine versus oral N-acetylcysteine. We often do IV. Oral can make people really nauseous. Folks don't like it. But IV, you usually give a kind of first bolus over 60 minutes, 150 milligrams per kilogram. You then usually get 15 milligrams per kilogram over 4 hours and 100 milligrams per kilogram over the next 16 hours. Again, this is a 21-hour protocol. Watch for anaphylactoid reactions. This can happen. It's not common, but it's common enough to definitely be mindful of it. Otherwise, N-acetylcysteine NAC is a fairly safe drug. Continue N-acetylcysteine until the Tylenol level is undetectable, the acetaminophen level. Liver function tests are improving, and your INR comes down. All right. So supportive care and monitoring. What you're going to support and monitor are going to be related to the toxicity the acetaminophen causes. So you want to monitor labs at least every 12 hours, but sometimes even more than that. And then you want to watch for all these complications: hypoglycemia, coagulopathy, encephalopathy, acute kidney injury. If it was an intentional overdose, obviously you need to address the reason for the intentional overdose with psychiatric support too. But you want to watch for all these complications. Sometimes lactic acidosis as well you want to monitor for. Obviously you're trending your liver function tests as well, watching their hemodynamics, all that stuff. So these patients can get really, really sick and require lots of monitoring, and sometimes require that monitoring to be in the intensive care unit if the ingestion was significant enough. So special populations you need to be aware of. Those that took extended release products. We've talked about this a couple times because this just makes things very complicated, right? The Nomogram doesn't work. You don't necessarily know when their peak effect is going to be because they get a delayed peak because they have extended release. So our suggestion is to have a very low threshold to give these patients NAC, independent of all the other stuff because they took extended release products. Chronic alcohol use or malnutrition, patients are higher risk to go into liver failure, so just know that. If you have a patient who has acetaminophen toxicity with chronic alcohol use or malnutrition. Pregnancy is obviously a really tough one. N-acetylcysteine is usually considered fairly safe, but again, verify that. Pediatrics, things become weight-based, and then unknown time from ingestion can make things really challenging too. But again, when in doubt, NAC it out. Give them NAC, give them N-acetylcysteine. So acute liver failure and transplant. We just wanted to shout out the King's College criteria. So as we've mentioned, patients who have acute liver failure from acetaminophen toxicity, many of them need transplant. But how do we predict those that might need a transplant? If you aren't at a liver transplant center, how do you know who you should transfer there? Well, those that need an early transplant referral, the King's College criteria from London, from King's College, studied it and found that anyone with an arterial pH of less than 7.3 or INR greater than 6.5, creatinine greater than 3.4, and grade 3 to 4 hepatic encephalopathy, or severe lactic acidosis. So these are all or statements. So anyone who's acidemic, anyone with severe lactic acidosis, or anyone with severe coagulopathy, acute kidney injury, and hepatic encephalopathy should all get early transplant referral. And this can be critical. This can be life-saving. This might be the only therapeutic option the patient has to save their life, liver transplant. All right, prognosis. Prognosis is excellent if N-acetylcysteine is started within 8 hours. Again, that N-acetylcysteine replenishes the glutathione stores. That glutathione then detoxifies the NAPQI, and then you don't have that NAPQI circulating around to cause liver injury. So NAC within 8 hours, prognosis is excellent. If the patient is in acute liver failure at presentation, the prognosis can be really poor, right? That's a patient that needs a liver transplant. Think about those King's College criteria. All right, we're coming to the end now. Just quick reference guide, and then we'll do some practice questions. So quick reference guide, remember toxic doses in adults are greater than 150 milligrams per kilogram or greater than 7.5 grams for kind of a quick cheat. So keep that number in mind. If the 4-hour level in someone who did not take co-ingestions, took only immediate release and has a really defined timeline, if that 4-hour level is greater than 150, treat. Let's get this out of here. Treat with N-acetylcysteine. But remember, you can't depend on this level on the Rumack-Matthew Nomogram if they took extended release or co-ingestions or the timeline's unclear, it's chronic, or what have you. So when in doubt, treat. But in someone who you kind of have a good timeline, it's all immediate release, you can use this Nomogram to help guide when to initiate NAC therapy. If their ingestion is within 4 hours, consider activated charcoal, and then always, 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 always call the poison center. All right, let's do a couple practice questions here. It's going to be, first one's going to be beginner, second intermediate, and third advanced. The way we'll do it is we'll read the question stem and answers, then we'll pause quickly, and then we'll talk about the answer. So if you need more time to think, just pause after we go through the answer options, and then just replay when you're ready to hear the answer. So question number 1 for beginners. 22-year-old female presents 3 hours after ingesting 15 extra strength acetaminophen tablets, 500 milligrams each. She's alert, mildly nauseated, has stable vitals. What is the next step? A, discharge with reassurance. B, send acetaminophen level immediately and await results. C, administer activated charcoal and obtain an acetaminophen level at 4 hours. Or D, start IV N-acetylcysteine immediately. All right, pause here if you need more time. The answer is C, give activated charcoal and get a 4-hour level. No need to start N-acetylcysteine yet if less than 4 hours. So the keys here are 1, 3 hours from ingestion, okay? So we don't need a level until the 4-hour mark. So we have a good timeline. It's 3 hours from ingestion. 15 extra strength, so we know the amount and the dose. And we know that 15 times 500, we'll probably do our math wrong, but it's about 7,500 maybe milligrams. So it's not quite above that for sure toxic dose. And then vitals are stable. So do we need a discharge for reassurance? No, this was a significant ingestion. We don't want to discharge. Do we send a Tylenol level immediately and await the results? You don't, because a 3-hour Tylenol level, if you remember, that Rumack-Matthew nomogram starts at 4 hours. So you wouldn't know what to do with a 3-hour level. If it's within 4 hours of ingestion, you can try activated charcoal, so that makes sense. And then obtain an acetaminophen level at 4 hours, so that makes sense too. That's when the nomogram starts. Start IV N-acetylcysteine immediately. You would not be wrong doing this necessarily because you're kind of at the 7,500 milligram amount, but it's not above that, and you also could get a 4-hour level and wait. But this is not the best answer. D, start IV N-acetylcysteine immediately, but it's not a horrible answer. But it's not the best answer. The best answer is to administer activated charcoal and obtain acetaminophen level at 4 hours. All right, intermediate level question. A 34-year-old man with chronic alcohol use presents 16 hours after ingestion of acetaminophen. Their AST is 800, ALT is 900, INR is 1.7, acetaminophen level is 22. What is the best management? A, no treatment needed. B, start IV N-acetylcysteine. C, discharge with follow-up. D, immediate transplant evaluation. All right, pause here if you need more time. The answer is B. Start IV N-acetylcysteine immediately. So this is a late ingestion. And we don't necessarily know what the formulary that they took are. They also have chronic alcohol use. So you want to treat with N-acetylcysteine despite low acetaminophen levels for a couple reasons. So the keys here are 16 hours after ingestion. Okay, so they are way beyond the acute phase. They have elevated liver function tests, right? They have an elevated AST and ALT. They have chronic alcohol use, so they're higher risk. And they still have acetaminophen in their system at 16 hours. So because of the elevated LFTs in particular, you're going to start N-acetylcysteine immediately. You definitely want to treat. You definitely don't want to discharge. And the immediate transplant evaluation, we tend to use those King's College criteria. And we don't have all the data in this question stem, but this would be a pH of less than 7.3, right? This would be an increased lactic acid, or an INR that's high, acute kidney injury, and hepatic encephalopathy. So he doesn't quite meet any of these, so he doesn't need an immediate transplant evaluation, but you should be starting N-acetylcysteine. All right, last question, advanced. A 50-year-old female, 24 hours post-ingestion, arrives confused, jaundiced, tachycardic. Labs have a pH of 7.28, a lactate of 6, AST of 5,200, INR of 7, and creatinine of 3.8. What is the best next step? A, supportive care. B, stop N-acetylcysteine. C, continue N-acetylcysteine and initiate urgent transplant evaluation. Or D, immediate dialysis without N-acetylcysteine. Pause here if you need more time. We kind of talked about this in the last question. The answer is C, which is continue N-acetylcysteine and initiate urgent transplant evaluation. So the key here is that this patient meets those King's College criteria, right? They actually meet multiple of them. They meet the one that is pH of less than 7.3, because this patient's pH was 7.28. They meet the one that is elevated lactic acid, because this patient's lactate was 6. And they meet the one that was INR greater than 6.5, creatinine that's elevated, I can't remember the exact amount, and then hepatic encephalopathy, because they're confused. So they actually meet all the King's College criteria. You obviously want to continue the N-acetylcysteine, but you want to transplant or refer them to a transplant referral center as soon as you possibly can, because they might need a liver transplant to save their life. All right, that's all we have for you today. We appreciate you checking out the episode. Remember, we do have a High Yield Patreon page with this study guide as well as practice questions linked in the episode description. We also have a podcast and this YouTube channel as well, depending on if you're either listening to this or watching this. So we'd appreciate you checking those out too. We'd love for you to join any of those. We appreciate you all. Let us know what thoughts, comments, questions you have. And either way, stay well and keep learning.